Good evening, everyone. Hopefully, audio video is clear to you. So, in this session, we will be discussing the high-yielding MCQs or the topics which are very important for your upcoming FMGE exam. So, hopefully, audio, video, everything is clear. We can start with, and in this series, we will discuss GIT, respiratory medicine, and cardiovascular system of the medicine. So, starting with the first set of questions, and the first set of the question is on the respiratory system. So, question number one. Hopefully, all of you must have given the test in your eMedicoz app. Starting with the question number one. A 70-year-old post-operative bedridden patient develops sudden onset of breathlessness and chest pain. Which investigation for screening the etiology of this presentation? So here, read the question very carefully. They are asking about the screening test for that etiology of the presentation. So whenever these words are given to you, bedridden patient, post-operative patient, and sudden onset of breathlessness, in that condition, the probable diagnosis will be, most likely diagnosis will be pulmonary embolism. So this is your topic, and this is a very, very important topic, a very, very frequently asked question, last moment revision topic for all of you. So for pulmonary embolism, D-dimer tests are considered to be the most sensitive test, and hence it is a screening investigation. While pulmonary angiography is a confirmatory investigation, or you can say it is the gold standard investigation for diagnosis of pulmonary embolism. For the pulmonary embolism confirmatory. So question is asking ki what is a screening test? So always go for a D-dimer test, and your answer for pulmonary angiography will be when confirmatory investigation is asked. While Doppler of the lower limbs, it will not be positive in all the cases, only 50% they will be positive. So this is not a very good test to screen for the pulmonary embolism. Again, chest X-ray is not sensitive for diagnosis of pulmonary embolism. So investigation of choice will be pulmonary angiography, CT pulmonary angiography. Yes. So most of you have given me the correct answer for this question. Answer is A option. D-dimer will be the correct option here. Now, moving on to the next one. So know this point, do this topic of pulmonary embolism. Very importantly, radiology as well as medicine, respiratory medicine. Correct. Now come to question number two. Question number two is on obstructive airway disease. Definitive diagnosis of bronchial asthma can be based on the basis of. So what will we do if patient is post RTA, road traffic accident? Road traffic accident within 24 hours, then it will be a fat embolism. And for the fat embolism, the treatment is conservative treatment. Now, definitive diagnosis of bronchial asthma can be made on the basis of the most important thing here is bronchial asthma is a obstructive airway disease. So in the obstructive airway disease, to make a diagnosis of bronchial asthma, obstructive airway disease. Important point is the ratio FEV1 upon FVC. That ratio will be low. So this is reduced. The ratio is reduced, and but this will tell us that it is an obstructive disease, and whether it is a reversible airway disease. Reversible obstructive airway disease is bronchial asthma, reversible component. So in that case, you have to prove that FEV1 should increase by more than 50%, 15% after a bronchodilator test. And absolute value will be more than 200 ml after bronchodilation. So that will prove it is a case of bronchial asthma. Otherwise, like COPD, bronchiectasis, obstructive pattern will be seen as a ratio will be reduced, and low serum alpha-1 antitrypsin deficiency will be seen in if it is a, of course, alpha-1 antitrypsin deficiency induced emphysema. So that make a diagnosis of etiology of the emphysema. While wheezing will be seen in all obstructive diseases, while HRCT is the investigation for bronchiectasis for HRCT. So the answer here will be B option for bronchial asthma. So bronchial asthma investigation wise is a important topic for you. Now moving on to the question number 3. Okay, let me see who can give me the correct answer here. So question is, a patient present with a high grade fever, cough and confusion with diarrhea. Chest X-ray shows bilateral infiltration in both the lower lung fields. Serum sodium. This is serum sodium that is given to be as 126. 126. Which of the following organism is responsible for this case? What if 12 is given? So 12 will not be given. It will be 15% which will be given to you. So serum sodium is low and bilateral infiltration is seen in lower lobes. So the answer for this will be Legionella, because Legionella causes SIADH, and SIADH means serum sodium will be low. So sodium value is low here. All of you know the normal serum sodium value 135 to 145. So the best answer here will be Legionella. Why not Streptococcus? Streptococcus leads to consolidation, while pneumocystis jirovecii, here the HIV positivity will be given, or immunocompromised patient should be mentioned in the MCQ, immunocompromised. And as such, pneumocystis does not cause SIADH, while Klebsiella will lead to bulging of horizontal fissure. Horizontal fissure. That will be the X-ray finding in the Klebsiella pneumonia. So out of this, the best option will be the Legionella. Now my question to you, let me see who can give me the correct answer here. What is the drug to be given is Legionella pneumonia? So that can be your potential question. So how will you treat? Which antibiotic will be helpful here? Whether it will be beta-lactam antibiotics, whether it will be aminoglycosides, whether it will be macrolides. So which antibiotic will be preferred in treating a case of a Legionella pneumonia? Yes, anyone can let me know the answer here. The treatment for Legionella pneumonia, whether it is beta-lactam like amoxicillin, whether it is amikacin, or whether it is macrolides. So answer ceftriaxone. No, beta-lactam is not ceftriaxone. It will be macrolides. Beta-lactam, ceftriaxone will not be effective in cases of Legionella pneumonia. Yes, it will be azithromycin. Klebsiella upper lobe. Yes, Klebsiella causes the upper lobe involvement usually. Upper lobe involvement. Yes. Now coming to question number 4. So question number 4 is, which of the following is not a cause of a transudative pleural effusion? So transudative pleural effusion, here the most common cause is cardiac failure. Most common cause is cardiac failure. While a liver cirrhosis, nephrotic syndrome, they are also the causes of a transudative effusion. While rheumatoid arthritis causes exudative pleural effusion. Exudative. And the criteria which is used here are Light's criteria. So that is must for you to know the Light's criteria. So the Light's criteria is any one of the following features will make the diagnosis of exudative effusion. So these will be if the pleural fluid pleural proteins divided by serum protein. If this is more than 0.5, yes, this is a Light's criteria, or a pleural fluid LDH divided by serum LDH more than 0.6, or the pleural fluid LDH is more than 2/3 of serum LDH, of the serum LDH. These constitute the Light's criteria. Very, very important. Exudative effusion is due to rheumatoid arthritis. Indeed, the most common cause of exudative effusion is pneumonia worldwide. Parapneumonic effusion, yes, very nice. Ratio, you know, the LDH ratio is more than 0.6, protein ratio more than 0.5, and serum pleural LDH more than 2/3 of the upper normal limit of the serum LDH. That is a Light's criteria. So this question revise your diagnostic criteria for exudative effusion. Light's criteria, yes, very nice. Now, question number 5. So question number 5 is in your exams, they gave some clinical questions as well. So clinical question about the examination of a respiratory system. So dullness to percussion and bronchial breath sounds at the left infrascapular area is seen in which of the following conditions? So if you see the percussion finding in the respiratory system are very, very important findings. Consolidation, pleural effusion, COPD, fibrosis. There are results of the percussion finding. So in the consolidation, it will be dull. Pleural effusion, it is stony dull. Stony dull. So for this, I am getting the wrong response. No. B will not be the answer. Stony dull will be the finding in the percussion. For the COPD, because of the air retention in the lungs, so it can be hyper-resonant. Fibrosis, impaired dullness. Impaired between normal and the dull. It is impaired. Shifting dullness, no. Shifting dullness, you are confusing. Shifting dullness is seen in ascites, while the breath sound. So see the combination. What will be the breath sounds in these conditions? Consolidation, bronchial breath sound. For the pleural effusion, it will be decreased breath sounds. COPD, breath sounds, they will show rhonchi. And the fibrosis reveals crepitations. Positive. So bronchial breath sound will be seen in consolidation, and in the pleural effusion, breath sound will be reduced. And also percussion will be stony dull. What is the meaning of the stony dull? When you percuss, there is a resistance from inside due to the effusion. That is known as stony dull. Like you are percussing on some stone, that is a resistance from inside. So the answer here will be consolidation. So that will be the correct answer here. Do not mark these questions wrong. These are very stat and important clinical questions. Yes. Now come to question number 6. Okay, so in the question of respiratory system, ABG is also important topic for you. Arterial blood gas analysis. The formula here is simple. That formula is look at the pH and look at the PaCO2. If they are going in the same direction, it is a metabolic condition. Very simple. pH is low, CO2 is low. So pH is low is acidosis, and CO2 is also going low. So it is a metabolic acidosis. Simple. Now, if pH and PaCO2 opposite direction, they are going in an opposite direction. So it will be a case of respiratory condition. Simple. So you will be aware of the normal values. The normal value of the pH is 7.40. Normal value of PaCO2 is 40 millimeter of mercury. 40 millimeter of mercury. Now, so when you look at the questions, only one options are given here. So first look at the pH. pH is low, it is acidosis, and look at the CO2. CO2 is also low, so it is a case of a metabolic acidosis. So 2 options you should focus upon. Rest you can rule out. These are not the causes. Now anion gap is being mentioned, so you have to calculate the anion gap. Anion gap is nothing but a difference of sodium minus chloride plus bicarb. So sodium is 140, chloride is 110, and bicarb is 10. So it is coming out to be 20. Normal anion gap is 10 is the normal value, or we can say take it as a plus 12 plus minus 2. So this you can take 12 plus minus 2. That is a normal anion gap. That means it will be from 10 to 14. 10 to 14 will be the range, 10 to 14. So it is a high anion gap metabolic acidosis. Simple answer. It will be a high anion gap metabolic acidosis. Very nice. Now come to question number 7. So question number 7 is on the cardiovascular system, and this topic is coming in every exam. In every session, they are asking the question from this topic of the cardiovascular system. So what is this topic? Muffled heart sound, hypotension, and distended neck pain. This classical triad, hypotension, distended neck pain, is nothing but a Beck's triad. This is a Beck's triad. And Beck's triad is seen in cardiac tamponade. This is in cardiac tamponade. So cardiac tamponade is a very, very important topic, and one of the important feature of the cardiac tamponade is in the JVP. Why descent will be absent? What are the other finding in the JVP? That can be the next potential question for you. In the JVP, you will get a large A wave. In the JVP, you will get a deep X descent. These are the other findings which are seen in cases of a tamponade, Beck's triad tamponade. What is the treatment of choice for cardiac tamponade? Treatment of the choice is pericardiocentesis. Pericardiocentesis. Everything is important about the cardiac tamponade. Now, moving on to the next one. Yes, it is a case of obstructive shock. Now, question is on the ECG. So question is, which of the following ECG finding is seen in a patient with a Wolff-Parkinson-White syndrome, WPW syndrome? So the ECG finding in a WPW syndrome, let's see what are the options given. P mitral. So P mitral means in lead 2, P wave width will be increased. P wave width will be increased. So what does that suggest? That will suggest left atrial enlargement. Left atrial is large. Breath will be more than 2.5 mm. Now, delta wave is this wave that in the initial part of the QRS there is a slanting. That slant is known as delta wave. That initial slant, I will make it bold. This initial slant of the QRS, yes, this is a feature of a WPW syndrome. And also the PR interval will be short. PR interval will be short here. WPW syndrome, PR interval short. Now, what about the Osborne wave? So, can anyone tell me what is Osborne wave? Osborne wave is this wave. Just after the QRS, instead of a point, there is a wave, and this is seen in cases of hypothermia. Yes, this is hypothermia. Other cause is hypothyroidism. Other cause is hypothyroidism. Yes, great. Now, epsilon wave. Epsilon wave is this wave. Double slurring is seen after the QRS complex. Look at the arrow. Double slurring. This is epsilon wave, and epsilon wave is known as the this type of double slurring wave. This is double slurring wave. It is seen in arrhythmogenic, yes, arrhythmogenic right ventricle dysplasia. ARVD, arrhythmogenic right ventricle dysplasia. So these are the other examples of the classical finding in the ECG. What are the other causes of those classical findings? Now come to the next one. Rabbit ear. No, rabbit ear is typically seen in right bundle branch block. Right bundle branch block. Now let me see who will give me the correct answer here for the Duke's criteria. So, your answer. Patient is intravenous drug abuser, presented with fever, 38.5 degrees Celsius, TLC is 20,000. Blood culture report is pending, and there are Roth spot on the fundus examination. How many minor Duke's criteria are present for the condition here? For the condition here. So let me see. I will. Who will give me the correct answer here? So major criteria and the minor criteria. Duke's criteria. So the major criteria are infection evidence. Number 2 is echo or CT evidence of vegetation. And number 3, this has been introduced as a major criteria, that is during the surgery, direct observation of vegetation. Directly we can observe the vegetation during the surgery. Surgeon can directly observe. While the minor criteria is predisposing factor, and the predisposing factor can be rheumatic heart disease or IV drug abuse, which is present here. While number 2 is presence of fever, and fever should be more than 38 degrees Celsius, which is all present here. Number 3 is immune phenomena. And one of the immune phenomena which is given here is Roth spot. Why? Vascular phenomena, which can be, for example, stroke, petechiae, like this. And 5th is the investigation but not satisfying major criteria. Like for the major criteria, 2 blood cultures are needed for typical organisms, but here only 1 blood culture is positive for typical microorganisms, so not satisfying the major criteria. And number 6 is in the heart, FDG PET scan positive in the heart. And number 7 is new valvular regurgitation lesion. So these are the 7 minor criteria. Out of this, the last 2 are newly introduced. Yes. So this can be a potential question for all of you for your upcoming exam. Duke's criteria. It should be on your tips. So here, the intravenous drug abuse is a minor criteria. Fever of 38 degrees, second minor criteria. Raw spot is third minor criteria. So answer is D option here. So this is question number 9 on infective endocarditis. Yes, new onset of new valvular regurgitation. Now coming to the question number 10. So question number 10 is on the drugs which decreases the mortality in the CHF patient. So the drugs which decrease the mortality in the CHF patients are ACE inhibitors, or a combination of valsartan plus sacubitril, and beta blocker. Okay, I'm getting the answer as A option. Some are giving me as C, some are giving as B. Most common lesion in RSD, MS plus MR or MR. Most common lesion in the RSD is MS. Okay. So beta blocker, only three beta blockers are approved. Metoprolol, bisoprolol, carvedilol, spironolactone, and SGLT inhibitors. SGLT2 inhibitors like dapagliflozin or empagliflozin. So these are the agents which are shown to reduce the mortality, and out of this only one is given as ramipril, which is ACE inhibitor, So the answer will be C option here. Now moving on to the question number 11. Okay, so identify this murmur in the given diagram. So this murmur, as you know, is starting from the S1 continuing till S2. So this is a pan-systolic murmur. This is a pan-systolic murmur. So pan-systolic murmur causes. So the diagnosis here will be MR. So MR causes pan-systolic murmur. Other causes of the pan-systolic murmur are TR and ventricle septal defects. Ventricle septal defect, this is not AS. In the AS, it will be ejection systolic murmur. So ejection systolic murmur is like this: S1, S2, showing increasing, decreasing trend. Increasing and decreasing trend, that is ejection systolic. And other causes of the ejection systolic murmur are pulmonary stenosis. While mitral stenosis is a mid-diastolic murmur. It is a mid-diastolic murmur. So the diastolic murmur will be S2, S1, and this is the morphology of mid-diastolic murmur. Other cause of mid-diastolic murmur, tricuspid stenosis. Whatever valvular disease is of the left side, same right side valvular disease causes the same type of murmur. So it will be mid-diastolic murmur. VSD also have a pansystolic murmur. Yes, VSD has a pansystolic murmur. And yes, HOCM can also be a cause of ejection systolic murmur. Very nice. HOCM can cause ejection systolic murmur. Now, aortic regurgitation is early diastolic. Early diastolic is this: S2, S1, this one. This is early diastolic. Acute rheumatic fever also has a mid-diastolic murmur. Yes, that is a Kerry-Coombs murmur, but there will be no pre-systolic accentuation in Kerry-Coombs murmur. So the answer here will be mitral regurgitation. It is a case of a pan-systolic murmur here. Yes, early diastolic murmur. Other cause is pulmonary regurgitation. This is here. So right side valvular disease will be pulmonary regurgitation. So this is an important page for you to revise the all the valvular disease murmur, which valvular disease cause which type of the murmur. Yes. Now come to question number 12. So question number 12 is patient present with dyspnea and dizziness, and very importantly, there is bis variance pulse. Bis variance pulse is there. PH also have a early diastolic murmur. Remember, alone pulmonary artery hypertension does not cause the murmur. It is, if it is causing pulmonary regurgitation, then it will be early diastolic. Know this very important point. Now, double apical apex impulse is present, and there is a diamond-shaped systolic murmur. Diamond-shaped systolic murmur is nothing but ejection systolic murmur. Ejection systolic. And it is heard at the third left intercostal space. Third left intercostal space is ups area. So this is ups area. So all the features are going in favor of HOCM. Why not it is aortic stenosis? Because it is a ejection systolic murmur, but at the right second intercostal space. That is aortic area. While mitral valve prolapse causes a late systolic murmur. Dilated cardiomyopathy is a pansystolic murmur. So the correct answer here will be HOCM. While very importantly, the maneuver which are reducing the blood flow increase the murmur of HOCM. And those maneuver are Valsalva maneuver and standing. Remember this point. Valsalva and standing, they decrease the blood flow into the heart. Only two murmurs. Only two murmurs increase when blood flow is reduced into the heart. These are MVP and HOCM. MVP and HOCM. Yes, HOCM is the most common cause of, one more MCQ, most common cause of sudden cardiac death in young. It is HOCM. Banana shaped LV cavity is a feature of HOCM. Now come to question number 13. Patient is admitted in the ICU, suddenly develops these ECG changes. What is the most likely precipitating cause of this arrhythmia? So if you can see this arrhythmia, the QRS complex are showing a decreasing trend, then increasing trend, decreasing trend, increasing trend. So this is nothing but a diagnosis of torsades de pointes. So this is a torsades de pointes which is happening, and torsades de pointes is precipitated by prolonged QT interval, and the most important precipitating causes are low magnesium, low calcium, and rarely low potassium. Low potassium is a rare cause but possible, while hyperkalemia does not cause prolonged QT interval. So it does not cause torsades de pointes. Know this very, very basic point. Hypernatremia, hyponatremia, they does not affect the ECG. They does not affect the ECG. So whenever these are given in the option, rule them out. So only option is hypomagnesemia. Yes, this is how we can rule out the option. Yes. Now come to question number 14. So question is, identify the wall of the MI from the given ECG. So again, in one question, you can identify the wall, like inferior wall will be the lead which will show ST elevation R2, 3, AVF. Lateral wall will be 1 and AVL as well as V5, V6. Anterior wall is V3, V4. Posterior wall will be V7, V8, V9. Yes, what question I am getting? I am getting the question as the A option. Let me see which wall MI is this. Some are saying A, some are saying B. Look at the option carefully. Lead 1 is showing ST. This is a baseline of the ECG, and you see the ST elevation in lead 1 and then move to lead AVL. They are in the same side. So this is also showing ST elevation. So this is a lateral wall. 1 and AVL are showing the ST elevation. So this is a lateral wall MI. So this is not inferior wall. This is lateral wall MI. Now come to question number 15. Question number 15 is tall T wave and wide QRS will prolong PR interval is seen in which condition? So in hypokalemia, instead of tall T wave, it is a small T wave. QRS normal, though PR interval will be prolonged. But the most important thing is U wave prominent. This is the most important point here, that will be U wave prominent in hypokalemia. While hyperkalemia produces a tall T wave, QRS will be wide, PR interval will be prolonged. So these are the manifestation here, and it will produce a small P wave. Small p. And hypo and hypernatremia, no ECG changes. No ECG changes. So answer here will be B option here. B option here. So where cardioversion and defibrillator used, know this point, cardioversion is correcting the arrhythmia into a sinus rhythm. It is a journal term. So cardioversion can be done by drugs when patient is stable. Cardioversion can be done by DC shock when patient is unstable. If QRS are normal looking, go for synchronized. QRS are bizarre, polymorphic, go for the asynchronized DC shock. And asynchronized DC shock is known as defibrillation. So this is the meaning of cardioversion and the defibrillation. Now, moving on to question number 16. So question number 16 is first line treatment for a patient who developed this arrhythmia with a BP of 100/70. So let me see who can identify the arrhythmia here. Diagnosis of this arrhythmia. I will give you the hint. Hint is QRS is normal. P wave is absent. Think of only two arrhythmias here. QRS normal, narrow complex tachycardia. It could be AF, atrial fibrillation, or it could be PSVT. Difference, AF, irregular rate, PSVT, regular rate. So here you can see QRS complex are normal and in between there is no P wave, only T wave is seen. Between two QRS, only one wave is seen, that is a T wave. P wave is absent. And when you check the rhythm is purely regular rhythm. It is a case of PSVT. Yes, this is PSVT, not ventricular tachycardia. So this is a PSVT, regular rhythm, QRS normal, P wave absent. Patient is stable. So when the patient is stable, the first line will be carotid massage. If no response, then go for adenosine. DC shock, if patient unstable, patient is in shock. Patient is in shock. Am I wrong? It is given for ventricular tachycardia. VTech. So answer is carotid massage. They are asking the first line treatment. Next line treatment will be massage. Now, question number 70. Question is preferred drug for a hypertensive patient with diabetes is. So avoid beta blocker in diabetes because it will lead to decrease awareness of hypoglycemia. Diuretic again should be avoided because it can increase blood glucose levels. In practice, do we give carotid massage? Yes, commonly. So it is common, very common. Now, out of ACE inhibitor and CCB, we give ACE inhibitor because they also decrease the chances of nephropathy. So hypertensive with diabetes, ACE inhibitor will be the preferred agent in this condition. Now, question number 18. Question number 18 is what can be now the GIT questions. What can be given to eat in a celiac sprue patients? So in the celiac sprue patient, what can be given? You can give rice, potato. They can be given. So answer will be C option in a case of celiac sprue. Yes, nephroprotective is ACE inhibitor. Nephroprotective will be ACE inhibitor. Correct. Now, question 119. Which of the tumor leads to hyperglycemia, necrolytic migratory erythema with depression? Insulinoma. Insulinoma cause hypoglycemia. While glucogonoma cause hyperglycemia. The main feature. VIPoma causes secretory diarrhea. Diarrhea must be given. It is present in 100% patients. While carcinoid syndrome, it present with not only the diarrhea but also the flushing episodes. flushing episodes. So the answer here will be necrolytic migratory erythema. This is highly characteristic feature with depression of glucogonoma. Yes, the answer is glucogonoma. Vipoma is a pancreatic cholera. Yes, correct. Pancreatic cholera. Now, coming to the next question. Next question is question number 20. Okay, now I will wait for your answer. What is your diagnosis in this condition? Patient of a chronic liver disease present with fever. Fever is present here. Ascites was present, and in the ascitic fluid, neutrophil were found to be 500, and SAAG ratio, SAG gradient is more than 1.1. What is your diagnosis here? Whether it is a ascites due to chronic liver disease, or whether it is cancer, or whether it is a spontaneous bacterial peritonitis. So answer, whenever fever history is given, always think of infection. And when the neutrophils in the ascitic fluid is more than 250, that is a diagnosis of spontaneous bacterial peritonitis. And the treatment of choice, drug of choice is cefotaxime, that will be given here. So answer is intravenous cefotaxime. While octreotide is given in hepatorenal syndrome treatment, large fluid paracentesis is given if respiratory distress is there. Respiratory distress. So answer is SBP, spontaneous bacterial peritonitis. Most important diagnostic criteria is neutrophil count in the fluid more than 250. That is diagnostic hallmark. Now moving on to 21. Question number 21 is patient present with fever, a diarrhea of 3 days duration, and patient has a course of cephalosporin, and counts are 18,000. So what is the most likely cause of this patient and preferred treatment? Preferred treatment. So the answer here will be, what do you think? Whenever there is a diarrhea after antibiotic use with high TLC count, always and always suspect the Clostridium difficile infection. And nowadays the drug of choice is replaced to fidaxomicin, not metronidazole. So answer is C option. Now the drug of choice for a Clostridium difficile is fidaxomicin, that is given here. Now come to question number 22. Patient presents with chronic diarrhea with blood in the stool and migratory polyarthritis. Know this point. Migratory polyarthritis is the keyword here. With diarrhea, always and always think of two conditions. Migratory polyarthritis with chronic diarrhea. The conditions are IBD, inflammatory bowel disease, or Whipple disease. And in the intestinal biopsy, if pass positive macrophage are seen which contain the bacilli, so that goes more in favor of a Whipple disease. Whipple disease. While it will be cryptapsis, while it will be in Crohn's disease, IBD, non-caseating granulomas. And here, caseating granuloma. So answer is B option. Whipple disease will be present, pass positive macrophages. Now come to question number 23. Question is, patient complained of fatigue, dark brown urine, and bilirubin levels are high. And out of this serum bilirubin, it is mainly a direct reacting which is elevated, direct bilirubin. So what will be the cause of this condition? In the hemolysis, it is a indirect bilirubin elevation. While Gilbert syndrome, again, indirect bilirubin is high. So it means A option not there, D option is not there. We are left with two options, acute viral hepatitis and pancreatic cancer. In both the condition, direct bilirubin will be elevated. Direct bilirubin will be elevated. But here, the liver enzyme which will be elevated, ALT will be high. Why? ALP will be high in pancreatic cancer because it is a obstructive disease, obstructive jaundice. So very, very high acute viral hepatitis. Simple answer. It is less than 40. Now here it is 1000. Now here it is 1000. P will be the answer. Now, coming to this question, patient is HBS reactive and the anti-HBC IgG is positive. So, whenever IgG is positive along with the surface antigen, it will be a case of chronic hepatitis. While in acute hepatitis, along with the HBS antigen, you will get a anti-HBC of IgM type. So that clincher diagnosis of acute hepatitis B. Now, what about the window period? In the window period, HBS is negative and anti-HBS is also negative. What is positive here? Positive will be anti-HBC IgM will be positive here. So the answer here will be a chronic hepatitis B infection. Chronic hepatitis B infection. Yes. Now, moving on to the last question. Last question is on chronic hepatitis. So, chronic hepatitis patient is 12-year-old boy, presents with a CNS abnormality like tremors, and there is a brownish green colored ring around the cornea. What is the likely diagnosis? So, this ring is KF ring, the classical diagram. This is a KS ring. So, the answer here will be Wilson's disease. And the drug of choice for the Wilson disease that we give is zinc. Wilson disease, it is zinc. And they ask about the gene which is mutation ATP7B is the gene which is affected in the Wilson's disease. So, these are the high yielding questions for GIT, liver, respiratory system, and the CBS. Important topics I have discussed. So, if you have any doubts, question you can put in the comment section, and wishing you all the very best for your upcoming exam. See you.